Good afternoon, everyone. Welcome to Unacademy, where you can crack NEET PG with us with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation for field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. Today's topic is monitoring depth of anesthesia. We will complete this topic today. We'll revise yesterday whatever we did and complete this topic. So Unacademy is one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. What will you get out of Unacademy? So at Unacademy, basically we have our daily life classes. So when you go to basically when you have to go when you have to go to work, so you have, I mean, when you have to go for a class, you have to get up, get dressed, get ready. It's a lot of time waste, a lot of energy waste. Then once you reach your coaching institute, you need to sit down, you need to get it. It might not always be easy to get your educator's attention, right? That might be a little difficult. So again, that becomes a problem, and your educator might not be able to clear everyone's doubts, because for the educator also it is a problem because they are time bound, right? So it becomes a little problematic. Their flow gets disturbed while you ask a question, etc. But over here, you can chat with your educator and engage in discussions all while the class is going on, and your educators will clear your doubts, right? So these are all structured courses. So the educators have researched and whatever is needed for your from NEET PG point of view, based on that, your courses have been prepared. Then of course live tests and quizzes. So the educators have prepared live tests and quizzes which will evaluate your preparations on a regular basis, and hence you all can get a detailed analysis on your performance. And then unlimited access, so one subscription can get you access to all our live and recorded courses, and you can watch from the comfort of any of your devices. So wherever you allow, whatever you all may be doing, from the comfort of your devices, you all can watch the live and recorded classes. Then these are some of top educators. Dr. Nikita Nanvani, Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Preeti Sharma. So now, Dr. Nikita Nanvani is a NEET PG mentor for radiology as well as mnemonics and concept, focusing on must-know topics and which encompass all subjects. And so the best part is that so mnemonics is very helpful. So from that point of view, so basically, those of you who prefer, like those of you who uh, I'm sorry, those of you who mnemonics helped, it would be really good that you all can go through this. So it will be good for y'all if y'all make your own. It would be really good. Then these are some of the courses offered. So as you can see, uh, these are now out of the many courses that so you all have to cover all the subjects. Subjects are not easy. It has been difficult for you all, I know. Now to cover these subjects, uh, like I said, these subjects are not easy, but it has to be done, and you all have to do it within a period of a year or 6 months or whatever, and they can ask you anything from any subject. Itself is so vast. So subjects like anesthesia, psychiatry, radiology, dermatology have been allotted 11 marks each. Now these subjects, from the point of view that these subjects, like I said, you all didn't have to go into detail during MBBS into these subjects. Here too, 11 marks each. They will not go into detail when they ask you questions, but to answer these questions, you all have to have read to some extent to be able to answer these questions. You all have to be aware of topics to be able to answer these questions. Otherwise, it will become difficult. Now, courses like physiology, anatomy, pathology, and all these have been allotted 44 marks each, and they can ask you anything from anywhere. You'll have spent almost a year studying each of these subjects, and can be asked to you from anywhere. These are some of the ongoing courses on our platform. That is course on neurophysiology, GI surgery, cardiovascular thoracic surgery, capsule on larynx, respiratory system, course on pathology, etc. Now coming to the NEET PG subscriptions, as you can see, there are 5 types of subscriptions on your screen. For those, 6-month subscription is ideal for those of you who are giving the exam this year. It should be sufficient. 12 and 24-month is what I would recommend, so you have a buffer period. It's more economical firstly. So with your 6 months, suppose you don't clear the exam after 6 months, or you get a subject you don't want, you want to give the NEET PG another shot, then you won't be able to come back and access this platform again. You will have to pay again. These are one-time subscriptions. However, with your 12 and 24-month subscriptions, you have that buffer time, right? And now with your 12-month subscription also, you see, your 12 and 24-month, it gives you time with the subject, right? With each subject, you're going through each subject, so it gives you some time to think about these subjects. Would you like to continue with these subjects? Do you like these subjects? Maybe something that you've decided on, you realize that you don't really want to go ahead with it, right? So like that, your priorities can change. So this time actually helps one to decide, right? So the 12-month, so like I said, my code SASHA to avail a 10% discount. This is the 10%. Now for your 24-month subscription again, you can use my code SASHA to avail 10% discount. Your 24-month too, nobody is really going to ask you how long you took to clear NEET. Why did you take so long to? Nobody will ask such questions, right? So now we will go ahead with class. So as we discussed yesterday, the aim of monitoring uh, the aim of monitoring the depth of anesthesia is to guarantee safety of anesthesia as well as the painlessness of the surgery, right? So it should be safe, there should be no overdose, as well as the surgery should be painless. So painlessness of surgery and safety of anesthesia. And the overall incidence of intraoperative awareness is 0.2 to 3%, right? So the overall incidence of intraoperative awareness is 0.2 to 3%. The incidence when more than 40 in patients of cardiac surgery, cesarean section, multiple trauma, and hemodynamics unstable patients. So the incidence is more than 40 in these cases, that is cardiac surgery, cesarean, multiple trauma, hemodynamic unstable. So this is some little history which is not required. So basically Artisio expanded. So Goodell basically gave the classification of the clinical signs of ether anesthesia into 4 stages: analgesia, delirium, surgical anesthesia, and respiratory paralysis. Artisio expanded Goodell's stage 1 analgesia into 3 planes, and that is no amnesia and analgesia, total amnesia and partial analgesia, and complete amnesia and analgesia. Woodbridge defined 4 components of anesthesia: sensory blockade of afferent impulses, motor blockade of efferent impulses, reflexive blockade of RS, CVS, and GI tract, and mental block or unconsciousness. Now, the modern concept is anesthesia is a complex interaction of multiple stimuli, diverse responses, drug-induced probability, non-responsiveness also to the stimuli. So it can be defined by hypnotic unconsciousness and analgesic relief component. So it can be defined by hypnotic, that is unconsciousness, as well as analgesic components. The hypnotic component can be created by intravenous and inhaled anesthetics, and the analgesic component by opioids and your local anesthetics, of course. So drugs such as ether, nitrous oxide. So these 3 drugs are both hypnotic and analgesic. That is your ether, nitrous oxide, and ketamine. Then coming to memory and anesthesia. So when it comes to memory and anesthesia, so memory is affected much before noticeable autonomic responses are seen. And the types of memory are short-term and long-term memory. So long-term memory can further be classified into explicit and implicit memory. So explicit memory is conscious memory, and it refers to conscious recollection of previous experiences. So recall test, so basically after general anesthesia, asking the patient whether he heard any sounds or words during operation. So long-term memory is explicit and implicit. Explicit is conscious memory, refers to conscious recollection of previous experiences, and recall test is after general anesthesia, asking the patient whether he heard any sounds or words, etc. during operation. So implicit is unconscious memory. It refers to changes in performance or behavior produced by previous experiences but without any conscious recollection. Long-term memory, it is chemically mediated process involving the NMDA receptors, and they potentiate memory retention by mechanisms called long-term potentiation. Ketamine blocks these NMDA receptors and hence antagonizes the long-term potentiation. These people have low incidence of recall. So propofol impairs conversion of short-term memory to long-term memory, more potent than volatile anesthetic. So midazolam produces intense anterograde amnesia, and diazepam produces milder amnesia of both types. Awareness, it only occurs under general anesthesia and the patient may recall some or all events during surgery and may or may not feel pain or pressure. So awareness is defined as a state in which the patient has no conscious recall but under hypnosis can exhibit considerable and accurate recall of events. So the incidence of awareness can be classified as 1.2%. So in 2000, the highest incidence is with trauma. The highest incidence of recall is with trauma, from 11 to up to 43%. Then comes your cardiac surgery, your general surgery, and then your obstetric surgery. Of awareness, so most common is sound and conversations, 89 to 100%. Then comes your sensation of paralysis, which is not a very nice feeling. Then comes anxiety and panic, helplessness and powerlessness, pain in 39%. Least common are basically visual perceptions, intubated, feeling the operation without pain. Those are the least common. So after effects of awareness, there can be sleep disturbances, repetitive nightmares, anxiety and panic attacks, depression, flashbacks, preoccupation of death, PTSD, post-traumatic disorder. It is seen in 14.3 to 22%. Then it can be seen from months, like 20 months to almost 17 years. Then stages of awareness. So conscious awareness with spontaneous or prompted recall, that is explicit recall. Conscious awareness with amnesia. Conscious awareness with unconscious awareness with amnesia, that is when your implicit comes in, and no evidence of awareness at all. So cause of awareness can be because of a lighter plane of anesthesia. So nitrous, opioid, relaxant anesthesia, or when there is no inhalation anesthetic, when there is myocardial depression, hypovolemia, cesarean section, difficult intubations, premature. Just a sec, guys, there seems to be some problem. Okay. So prevention of awareness is administer, basically administer amnestic premedicants, maintain vigilance regarding equipment and monitoring. So, monitoring has to be very stringent, and vigilance has to be maintained with regards to equipment and monitoring. Minimize use of complete neuromuscular blockade. Supplement nitrous opiate anesthesia with a potent volatile anesthetic. So volatile anesthetics actually help prevent awareness. Maintain a MAC of 0.8 to 1 of a potent volatile anesthetic. Administer adequate dose of induction agent. And obtain informed consent for high-risk patients. Provide education and monitor for awareness. Okay. Local anesthetics, then interaction surface relating the drug concentration to the probability of the given response to the given stimulus. So as the depth increases, first there will be loss to stimuli. So these stimuli are in increasing order of pain. So these stimuli are in increasing order of pain. As the cells progress from left to right and from top to bottom, large doses of anesthetics are required to suppress a given response to stimuli. Now, drugs and depth of anesthesia. So, your inhalation agents, purposeful movements of any part of the body in response to noxious stimuli is the most useful clinical sign of depth of anesthesia. So, any movement in response to pain is a sign of depth of anesthesia. Hence, MAC was defined as the minimum alveolar concentration of an inhaled anesthetic that was needed to prevent movement in 50% of the subjects in response to a painful stimuli, which was mostly the surgical stimuli. So, whereas your tracheal intubation is actually a much stronger response than the surgical stimuli to incision. So, MAC was expanded as MAC awake, MAC intubation, and MAC bar. MAC awake is minimum alveolar concentration that would allow opening of eyes on verbal command and emergence. MAC intubation is that would inhibit movement and coughing during endotracheal intubation, and MAC bar is that would prevent adrenergic response as measured by venous concentration of catecholamine. Now, induction agents, that is your non-opioid and IV. The plasma drug concentration peaks in half to 1 minute and declines rapidly. The depth of anesthesia allows plasma drug concentration estimation. Now, the clinical endpoints of assessment are the response, loss of eyelid reflex, and loss of corneal reflex. The strongest stimulation during induction is your laryngoscopy and intubation. and hemodynamics. So maintenance of anesthesia. The plasma levels of anesthetic agents are accurate predictors of brain levels of the drug and good indicators of anesthetic depth. So clinical endpoints for assessment, there will be loss of eyelid reflex, loss of corneal reflex, absence of movement in response to squeezing trapezius. So opioids in large doses need to be added when precise hemodynamic control is necessary, especially in coronary artery disease, right? So plasma levels of anesthetic agents are accurate predictors of brain levels and drug and good indicators of anesthetic depth. The CP50 is a steady state plasma concentration which will prevent purposeful movement through noxious stimuli. So clinical events increase which indicate inadequate infusion rates. So increase in BP, increase in heart rate, movements such as swallowing, coughing, opening eyes, lacrimation and sweating. Assessment of depth, cardiorespiratory rate and depth of respiration, blood pressure, heart rate, increase in blood pressure, increase in heart rate when the depth of anesthesia is light, not when the anesthesia is not deep, autonomic such as lacrimation, diaphorism, mydriasis, and somatic such as skeletal muscle movement. So the objective methods are your lower esophageal contractility, facial electromyography, EEG monitoring, and the EEG derived monitor, past spectral analysis, bispectral analysis index, narco trend, patient state analysis, and evoked potential. So all these depend on EEG, right? So your autonomic changes are basically there's acute hypertension. So it's basically the patient response to surgical stimulus. The score includes 4 hemodynamic parameters, that is your blood pressure, pulse rate, sweating, and tearing. Right. So this is your score. Pressure, pulse rate, sweating, and tears, and these are used as clinical indicators of lightening or depth to indicate the depth of anesthesia. These changes can be seen with the disadvantage of this PRST score is these changes can also be seen with events like hypotension, dehydration, hypoxia, hypothermia, sudden blood loss, then drugs like beta blockers, inotropes, vasodilators, antihypertensives, then hemodynamic changes that are seen with opioids, muscle relaxants, etc. can also show. Now pupil diameter. The changes are unreliable. So dilatation is affected by catecholamines, atropine opiates. Pupillary reflex is affected by opioids and anoxia. Then isolated forearm technique, the isolation of forearm from IV muscle relaxants. A tourniquet is applied on the arm and inflated before giving a muscle relaxant. Arm is unparalyzed. Patient will respond to commands if depth is not adequate, right? So ischemia might be a problem. Now coming to the objective method. So this is what we did today. The lower esophageal contractility, the non-striated muscles in the lower half of the esophagus retain their potential activity even after full skeletal muscle paralysis. Spontaneous and provoked lower muscle esophageal contractions reduce in latency and amplitude during general anesthesia. Spontaneous and provoked lower esophageal contractions can be reduced in latency and amplitude during general anesthesia. And it is measured using a balloon esophagus, which there is published evidence for this. Now, facial electromyography. Facial expression reveals stress and so facial expressions reveal stress and they can be abolished by anxiolytic drugs, sedatives, and general anesthesia. Spontaneous electromyography um, of frontalis muscle is used to monitor activity of the muscle under anesthesia. A monitor which displays the frontalis muscle power as a trend has been used in anesthesia, and it detects very light anesthesia. It is not of very great clinical value. Then electroencephalogram. So the EEG is a surface recording of the summation of excitatory and inhibitory post-synaptic potentials that are spontaneously generated by the pyramidal cells in the cerebral cortex. So it is a summation of excitatory and inhibitory post-synaptic potentials spontaneously generated by the pyramidal cells in cerebral cortex. So for perioperative use, identify inadequate blood flow to this. It identifies inadequate blood flow to the cerebral cortex, which can be caused either surgically or anesthetically induced. It is a guide to anesthetic induced reduction of cerebral metabolism, either in because of loss of cerebral blood flow in the treatment of high intracranial pressure, and it can be used to predict neurological outcome after a brain insult, and it can gauge the depth of hypnotic state of the patient under general anesthesia. So these are the benefits of the um, of the electroencephalogram. Now, EEG is low voltage, that is 5 to 500 microvolt, and deflect is a low voltage deflection that is recorded from the surface of scalp electrodes. Cerebral physiology and metabolism both affect the EEG, and anesthetic drugs affect both cerebral. So, cerebral physiology and metabolism affect EEG, and this cerebral physiology and anesthetic drugs affect both EEG as well as cerebral physiology. So different conditions result in different frequencies and amplitudes in the EEG waves. So waves are designated as alpha waves, that is 8 to 13 waves per second. Beta wave is more than 13 to 60 waves per second, and theta is 1 to 5, delta is 1 to 5, and theta is 4 to 8. As you can see, beta is 13 to 30, alpha is 8 to 13, theta is 4 to 8, and delta is less than 4. So anesthetics cause changes in cortical neuronal activity, resulting in changes in brain electrical activity. That is so induction, there will be increase in beta activity, deepening of theta or delta prominence, and further deepening there will be burst suppression. So anesthetics cause a change in cortical neuronal activity, which can result in brain electrical, which is reflected by the EEG basically, right? So like I said, anesthetic agents influence both the EEG as well as the cortical activity. So the effects of noxious stimulus on an EEG, there will be desynchronization with appearance of fast rhythms, appearance of 6 to 10 Hz spindles, bursts of 1 to 3 Hz slow waves. Anesthetic drugs result in low frequency and EEG burst suppressions at high concentration. So burst suppression is flat EEG with bursts of high amplitude, low frequency signals. So as depth is increased, intervals between bursts will also increase, right? So it will be prolonged. Now coming to the past spectral analysis, computer assisted analysis which facilitates for easier interpretation. So results are compared to conventional EEG. EEG signals can be broken into a series of component sine waves, typically 1 second long with frequencies ranging from 0 to 30 hertz. So EEG signals in power spectral can be broken into, it is basically sine waves 1 second long with frequencies from 0 to 30 hertz, like this sine waves. The power spectral represents each of the sine wave components as a function of frequency. So median power frequency is the point at which 50% of the power exists above or below its value. It is derived from EEG activity. Spectral edge frequency is frequency below which power spectrum contains 95% of total EEG. Bispectral analysis, okay, that analyzes the phase and frequency various components, right? So it measures effects of hypnotics on EEG. It is computed real time using combination of three analysis techniques. So past spectral, bispectral, and time based analysis. Okay, this is techniques, and it takes an average of these four parameters, that is your power, your frequency, the burst suppression, and the bispectral analysis that analyzes the phase and frequency among these components. Anesthesia awareness. 0.4 Mach is usually Mach awake, that is when the patient can be aroused. Then narco trend monitoring, that is basically perform automatic analysis of EEG during anesthesia, and there are six components. So when the patient is awake, the six components are awake, B is sedated, C is light anesthesia, D is general anesthesia, E is GA with deep hypnosis, and F is general anesthesia with burst suppression. So this is your narco trend monitor. As you can see D there, D is general anesthesia. Can you see the number, this D here? So D will indicate general anesthesia. So it basically has six components: A awake, B sedated, C light anesthesia, D general anesthesia, E is GA with deep hypnosis, and F is GA with burst suppression. So patient state analyzer. So the patient state analyzer is basically EEG derived color coded index recorded on a scale of 0 to 100. So it is basically an EEG derived color coded index. So green indicates a hypnotic state, that is 25 to 50. Yellow indicates a deep hypnosis less than 25. Blue is burst suppression, and white is discarded or artifact. So this is based on color. The indication over here for this is based on color. So like I said, it is an EEG derived color coded index. So as you can see, advantages are minimal interference with cautery, electromagnetic operating system, and noise pollution. Now as you can see, assess unlimited the level of consciousness with the physiometric patient state analyzer. So as you can see over here, this is the green, right? hypnotic state 25 to 50. Yellow is deep hypnosis. So as you can see here, this is the hypnotic state. So the monitors are basically, so for all these monitors, the monitors are basically okay. So this is how it is usually placed on the forehead, and that is how you can analyze. Then entropy. So entropy measures the degree of disorder or the lack of synchrony or consistency in a system. So it measures the disorder or lack of consistency in a system. The data is made a solution for monitoring the effect of anesthesia on the patient's central nervous system during general anesthesia. So Datex Omeda came up with this. So when used together with other adequacy of anesthesia parameters, you can provide safer sleep and faster recovery to each patient. So the algorithm that is used uses frequency analysis combined with burst suppression to measure entropy of the EEG. The entropy monitor reports two entropy numbers to aid in interpreting EEG analysis. So basically entropy will indicate two numbers to you. So what is measured? So based on acquisition and processing of raw EEG and FEMG signals, it measures the irregularity of signal. So it provides two parameters, response entropy and state entropy, right? So fast reacting, so the response entropy is fast reacting and it is sensitive to the activation of facial muscles. The state entropy is slower and is used for assessing the hypnotic effect of anesthetic drugs in the brain and detection of and display of EEG of the burst suppression ratio. So the response entropy tracks the changes in the EEG power in the higher state frequency ratio range of 0 to 47. The state entropy tracks changes in the EEG power in the frequency range of 0.8 to 32 Hertz. So as patient proceeds through deeper levels of unconsciousness induced by general anesthesia, the EEG pattern becomes more regular and ordered, right? That is, we observe the apparent decrease in entropy of the EEG signal. So let's see this more regular and ordered, the EEG pattern. That is when the patient becomes unconscious. So the clinically meaningful range of entropy seems to be linear. So entropy is fast to reach both extremities of the range. So both deep and awake values. So this is state entropy, this is response entropy, right? So response entropy is 100 and state entropy is 90. So fully awake and responsive. So 60-60 indicates clinically meaningful anesthesia and 40-40 is low probability of recall. So 100 to 90 is fully awake, 60-60 means anesthetic depth has reached, 40 is low probability of recall and 0 is suppression of cortical activity. So response entropy and state entropy are high, that means the patient is awake. Response entropy and state entropy are equal and low, stable hemodynamics, patient not moving, the patient is adequately anesthetized. If the response entropy is going up, state entropy remaining low, the patient may be about to move. Rule out if TOF is 0, the patient may be feeling pain. If TOF is 0, patient may be feeling pain. If the response entropy is going up, the state entropy is also going up, patient may be about to wake up. So these are the different scenarios. So if you can see, if during general anesthesia there is approximately 10-point difference between response and state entropy, the patient is likely to move in response to external stimulus. Okay. So low amount of hypnotics, high amount of hypnotics. So no neuromuscular blocking drug, light anesthesia your response entropy is more than state entropy, that is high. Deep anesthesia, the response entropy is lower than is equal to the state entropy. High amount of neuromuscular blocking drug, the risk of awareness, both will be equal. Risk of awareness will be high. And deep anesthesia, if there is low amount of hypnotics with high amount of hypnotics, deep anesthesia, both will be equal. So basically this concludes our class. So what did we learn? The basic so what we learned is the EEG. So one is your clinical analysis, your esophageal contractility and all that. That all we have covered. But also what we learned is with the EEG we can measure the so these are the methods of so the EEG derived monitors are your past spectral index. So these are the objective monitoring, your lower esophageal contractility, facial electromyography, then your past spectral analysis, bispectral analysis, narco trend, patient state analysis, and evoked potentials, right? So your bispectral index is basically like your burst suppression, uh, like your past spectral analysis. Then we have your bispectral analysis. It does not indicate analgesia effect, but it does indicate the hypnotic effect. Then we have the BIS, that is your bispectral index. So it goes on a number from 0 to 100, and 0 indicates no cortical activity, 100 indicates the patient is fully awake. So we would like the patient to be between 40 and 60 ideally, to know the optimal, that there is optimal depth of unconsciousness, right? So these are the couple of interpretations. 70 to 80 means loss of consciousness, 60 is probability of consciousness is low, less than 40 is deep hypnosis, 40 to 60 reflects adequate hypnotic effect with GA. So then we have our patient safety index. So the patient is unconscious when the range is between 25 and 40. Then we have our end-tidal anesthetic gas assessment. So when the MAC concentration is more than 0.7, this reduces the risk of anesthesia awareness to a very great extent. So generally MAC concentrations are kept above 0.7 to reduce the risk of anesthesia awareness. Then we have the narco trend monitor, where it performs automatic analysis of EEG using 6 components, that is A is awake, B is sedated, C is light anesthesia, D is general, E is GA, and with deep hypnosis, F is GA with burst suppression. So as you can see the D on the monitor over there, indicating general anesthesia. So for all, the electrodes are basically kept in the forehead for most of these monitoring devices. Then patient state analyzer, you have the hypnotic state, the deep. So based on color coding, it has been classified as hypnotic, deep hypnosis, burst suppression, and artifacts. Then we come to the entropy. Entropy is basically two types, response and state entropy. So two types of entropy parameters. Response entropy is sensitive to activation of facial muscles. The state entropy is assesses the hypnotic effect, and so when entropy is low, basically it is general anesthesia. It is more regular and ordered. Then response and state entropy, as you can see the values, 190 fully awake when the response and the state entropy are equal and little lower. It indicates more meaningful anesthesia and low probability of recall, and 0 is burst suppression of cortical electrical activity. So that's about it guys today for class. There will be a quiz in the evening, a mega quiz. So do stay tuned. This topic is a little dry, I know, but based on just those values you have to remember, and the way it is, what is used to measure those names like BIS, past spectral index, you all have to remember that, because awareness has to be prevented with anesthesia. So do use my code to avail your 10% discount, and don't forget to subscribe guys, hit the bell icon for notifications, use my code and you all can avail the discount. Thank you guys, have a good Sunday.